Um, my name is Annie Hardison Moody, and I am the director of the Faithful Families Thriving Communities program. And my apologies if you hear noise in the background. I tried to get away, but my 6-year-old has is virtual learning and just kind of following me around the house. So, and it's a good thing that I'm not presenting. So I am here to present or to share with you one of my colleagues, Dr. Cherie Conley, who is going to present her work on a peer support program that she developed in partnership with Faithful Families. And Dr. Conley is committed to health promotion among underserved and vulnerable populations. Her research focuses on health equity and developing community asset building programs and policies. This work in public health has taken her from Accra, Ghana, where she worked with researchers to promote breastfeeding for new mothers, to Baltimore, Maryland, where she used science experiments to talk about hypertension with African American men. Dr. Conley was inspired to pursue public health nursing after interacting with nurses while serving as a chronic disease management consultant. She respects the unique experiences of others and is a firm believer in collaboration across academic, public, and community settings for public health improvement. And I am really excited for you all to get to hear from Dr. Conley. This was a part of her dissertation research, which she defended this spring in really one of the most wonderful, can everyone mute your computers? Hang on, let's see if I can mute all. There we go. How today is going to work is Dr. Conley is going to present her research. And once she has done that, if you have questions along the way, you're welcome to put those in the chat box. I will then moderate questions after she's done with her presentation, and we'll start with the ones that are in the chat box. And then I'll ask you if you'd like to ask a question out loud, you can unmute and ask your question at that time. So if you'd like to speak your question, just write in the chat box question and I will call on you. And if you have any questions for me, feel free to send those during the chat as we are going through with the presentation. But Cherie, at this point, I will hand it over to you and welcome to the webinar.
Thank you, Annie. I'm so happy to be here and I appreciate the invitation to talk about this dissertation work that I did in partnership with you really and the Faithful Families community and program. So my presentation and the project was all about how to incorporate peer support into the Faithful Families Thriving Communities program. I really was interested for my dissertation in looking at sustainability of community health programs as well as equity. So that's how I kind of came upon this idea of peer support. And so what we'll do today, see if I can advance this. Okay, so today what I'll do for the time that we're here is give a little bit of background on peer support and health, talk about the preliminary study that we did for my peer support project, talk about the actual peer support project, how we designed and implemented it, go over the project results, and then some tips and lessons learned from the project. So first, the purpose of the project was just to look at the feasibility of integrating dyadic peer support into the Faithful Families Thriving Communities program. And we did it in 3 African American churches. And so we're all on the same page. Dyadic peer support simply means 2 people, 2 partners, a team of 2 people working together in order to try and achieve their goals. So I focused on peer support because, as I said, I was really interested in what's one avenue to helping community-based programs become a little more sustainable and maybe more effective. And what I found in the literature is that dyadic peer support is something that has been used in various health conditions, diabetes, weight loss, even depression. And generally they found that when working with another person, so 2 people instead of 1, you actually do a little bit better at achieving your health goals. So dyadic peer support, or adding a dyadic peer support component to formal health programs, has actually been recommended to maybe extend the effects of that formal health program. And although we've seen in African American churches community health promotion programs that utilize peer support, like group health education classes or lay health leaders, I hadn't seen in the literature many studies that use dyadic peer support focusing on weight loss and used in a way to augment an existing program. So that was the basis of my project. And after meeting, I read a little bit about Faithful Families, met Annie and felt like this would be a great program to partner with. It was established according to what I read and listened to. It was a really well-received program focusing on lifestyle, nutrition, and physical activity. Also, when I spoke to Annie, she said that many of the programs after it was over, participants said, well, what more? We want to continue. We want to do something else. And that was also the same time that the 4-week walking challenges were being developed. So it seemed like a great time to partner and a wonderful opportunity for me. So this was actually the flyer that we used to help recruit. So before actually starting designing and implementing a program, we wanted to see how potential participants as well as the PAs that might be helping, we wanted to find out how they perceive this idea of dyadic peer support to promote health, especially integrating it with Faithful Families. So we did this preliminary study. So we interviewed PAs as well as church members in these 4 different regions across North Carolina. The types of questions that we asked were, for instance, several questions, but the ones pertaining to dyadic peer support were, what do you think about pairing up with other church members in a health education class? And if you did pair up with another church member for a healthy eating or weight loss program, what would you want it to be like? And the themes that emerged from the interviews were, in essence, members were really eager to actually help one another and to help others and then to be helped by other members. They also gave very specific suggestions for how partners or dyads should work together and how the activity should be structured. And finally, they said a common theme was that working in pairs is natural and beneficial and kind of something that they already do in churches, so it would merge well with what's already going on. The biggest, I would say, challenges that the PAs or regional coordinators identified were, well, sometimes when we have Faithful Families classes, there's a lot of discussion, really robust discussion that goes on. So we don't know if pairing people up is going to be helpful or if it's going to be harder to get through the lessons. The biggest challenge that the members thought they might run into were being paired with someone who wasn't quite as motivated as they were. But by and large, participants in the interviews felt like it was a good idea and that pairing people up to work together might be helpful. So this is one of the quotes. I think that's an excellent way to achieve almost any goal because the scripture says 2 are better than 1. If one falls, the other one can pick him up. It also says, how can 2 walk together except they agree? So often in the scriptures, we got 2, where 2 are gathered. 1 can chase 1,000, 2 can chase 10,000. So you're always better off with a partner. So based on that preliminary study, we went ahead with designing the actual peer support project. And our aims with the project, first, we wanted to just, again, assess the basic feasibility. Is this something that can be done, adding a peer support piece to the existing health promotion program? The second thing we were interested in was, if we pair people up, how exactly do they work together? How do they encourage one another? How do they address challenges? How do they interact? And then finally, we were interested in what types of health outcomes were attained by participants working together. So coming up with this peer support project was a process. It was about a 2-year process since it was part of my dissertation. We spent about from April to December of 2017 developing the dyadic peer support component. From January to April of 2018, met with the the PAs who would be delivering the program talked about the program and kind of went over, brainstormed how it would actually unfold. And then from April to December of 2018, we recruited the churches that would be involved. And then finally from January to July of 2019, implemented the program. So this slide gives you an outline of the original Faithful Families program, which was the 9 weeks long. And then it has also an outline of the new peer support component, which is also another 9 weeks. So in total, the full program was 18 weeks long. So what happened was after the first 9 weeks, at the 9th class, participants were asked to choose a partner. After the 9th class, instead of dispersing as they normally would, they actually came back to the faith community for a dyad training session. This was a 90-minute session where participants sat with their teammates, so the dyad sat together, and we talked about goal setting. They wrote down goals that they wanted to achieve, one in nutrition and one in physical activity. They talked about assets that the team might share to help them achieve their goals. They talked about what motivated one another. We talked about challenges and how we might overcome challenges. And then finally, we talked about supportive communication and what that means when working with a teammate. After the session, participants left for the next 4 weeks. They worked with their team member and they didn't come back until after that 4 weeks. When they came back to the church, we met as a group, talked about progress, challenges, and strategies. After that check-in, then they left for another 4 weeks, and then finally came back to the church for one more class where they, again, just briefly went over progress, challenges, and strategies, and that was the end of the program. The only, outside of that, the 14-week check-in, the only interaction that, or communication that I had with participants was a weekly health education newsletter, the Faithful Families newsletters that were sent each week to participants' homes. So the data that we collected during the program was first, the Faithful Families entry and exit surveys, week 1 and 9, that was the standard. What we did was added one more exit survey at week 18 so we could compare. We also looked at collected information on weight, BMI, and blood pressure, weeks 1, 9, 14, and 18. And finally, because we want to find out whether or not partners are even talking to one another, we had them write down whether or not they were communicating with their partner, and we collected that information weeks 14 and 18. One thing that's not listed is that we also had participants write down how many minutes of physical activity they did each per day, and as well as how much fruit and vegetable intake they had per day. So as I said, we spent some time doing recruitment, face-to-face, email, telephone, word of mouth. We wound up with 3 churches across North Carolina who participated in the program, and 80 participants across all 3 churches. So the results of our study, again, we're looking at 3 different aims, 3 different things, just feasibility, looking at the attendance of participants. The second aim was how the teams and the team members talked to one another, communicated with one another, and supported one another in achieving their goals. And then that aim 3 was looking at the clinical and nutrition outcomes. So first, again, we consented and enrolled about 80 participants. From week 1 to week 9, which is the standard Faithful Families program, we had 65 participants who were able to complete that first 9 weeks. For the second 9 weeks, participants who started, it was about 65. The number who completed the second 9 weeks was 62. So overall, we had 62 out of 80 participants complete the entire 18-week program. So that was a 78% completion rate. And then when we look just at the participants who completed the second 9 weeks, which was the dyad part, that was about 62 out of 65, so 95% completion rate. In addition to attendance, in order to look at feasibility, we just looked at the number of dyads that we had. So we had 32 dyads, or really 31 dyads and one triad. As I mentioned, participants were allowed to pick whoever they wanted to pair up with. So we had about half of participants pick a friend, 40% picked a family member, and there were 8 people who said, I'll pair with anyone, it doesn't matter, I just want to participate. So those were people who I and the lay leaders matched with someone who maybe we saw them sitting with repeatedly during the group classes, or the lay leader knew that they had some type of connection. So we also found that participants communicated pretty frequently. Most people, over 80% of participants, communicated with their partner at least once per week, about 44% over 2 times per week. And the average was about 2.59. At the end of the program, all participants completed a feasibility study or a feasibility survey. So this was just a quick survey where participants were asked all of these questions. Would you partner again? Did you help your partner achieve their health goals? Was it easy to reach the partner? So all of these different questions about feasibility and acceptability of this program. And it was scored on a 5-point Likert scale. We had 95% of participants say that they would definitely partner again, that they agreed or strongly agreed with the statement that they would partner again. They felt it was easy to reach their partner, they liked talking with their partner, and they felt that their partner had helped them achieve their health goals. So the second aim was looking again, not just at a survey where participants said, yes, I liked working with my partner, but we wanted to go a little bit deeper into how participants, how they identified their goals, what kind of goals they identified for themselves, how they interacted and communicated with one another. Again, this is the dyads, how the dyads motivated one another, how they talked about challenges to improving their health, and how they strategized together as dyads to overcome some of those challenges. So in order to look at this more in depth, I did 42 interviews. So we did 7 dyads from each of the 3 churches, and then interviewed all of the PAs who were the ones that delivered the program. The types of questions that we asked were, tell me about your partner, tell me about the first week working together, how'd you motivate one another, and what were the challenges and strategies? So in terms of goals, we found that teams had both individual and shared goals, and they were encouraged again to do a physical activity and a nutrition goal. So often decreasing sugar, trying to eat out less, those were some of the common goals. We found that most interviews, well, just about all interviewees reported some type of improvement in health, some type of movement or progress in at least one of the goals that they had for themselves. We found that in terms of interaction, participants really did it all, text, phone, and face-to-face. We thought that they would really focus on face-to-face based on the preliminary study we did. Several people that we interviewed said that they didn't like text. It was really important to do face-to-face, but in this feasibility study, they really did everything. Although face-to-face was common, especially during Sunday service, what we found is that participants did pretty simple check-ins for the most part. So how are you doing? Is it going pretty good? They would often, find a little bit of humor in some of the challenges that they faced, but the check-in, they were more check-ins, not big, long, in-depth conversations. We found that in terms of motivation, participants felt that they were really, they felt supported, even with the short check-ins, even if they weren't able to talk to their team member often, they still felt that, as this quote says, they knew there was someone there that if they really did want to talk, they could talk to someone. So they really focused on positive encouragement, just being there for the other person, making sure the person didn't feel bad if they didn't achieve all of their goals. So really just being a soft landing. They also talked about the importance of motivating yourself. So while they liked having a partner, they also felt like, your partner could only do so much. It was really up to you to to get that self-motivation. So the main challenges that participants identified was lack of time, sometimes to prepare healthy meals or get in that physical activity because of work or because of traveling or just life events like having to care for another person like a family member. We found that they didn't always go into depth with their partner about all of the challenges that they were having. And so we felt like, so partners didn't always have a chance to really hash out lots of different strategies. We also felt that at times partners felt like they didn't want to feel like they were telling their partner what to do. So they treaded kind of lightly when it came to suggesting strategies. They were more likely to model behavior. So for instance, if one person said, I just can't get in these vegetables, the partner might say, oh, sometimes in the morning, I'll put vegetables into my smoothies and that's helpful for me to get in my, 7 a day. And so they would model behavior and share what they were doing as a strategy. There were also a lot of information exchanged during group class. They really enjoyed getting together. It took the pressure off and they really seemed to feed off one another. And that's where a lot of strategies were shared as well. So overall, their program experience that they shared during interviews reiterated what we saw in the feasibility surveys. They were positive, they liked working with partners, and they definitely had some suggestions for what we should do in the future for improvement. So the last thing we looked at were the health outcomes. We were interested in looking at the health outcomes trends from baseline all the way to week 18, so the end of the program. We were also interested in looking at and comparing changes during the first 9 weeks compared to the second 9 weeks. We looked at fruit and vegetable intake. We were interested in physical activity, of course, the weight, BMI, and blood pressure. So what we found were that the fruit intake, there was a significant and continuous improvement over the entire course of the program. So there was about a half a serving increase from baseline to week 9, and then another half serving increase from week 9 to week 18. And that was in the mean number of servings of fruit per day. In terms of physical activity, it was similar. We found that over the course of the whole program, there was continuous improvement that was significant, that was statistically significant. So from baseline to week 9, there was about 1 extra day of 30 minutes of physical activity per week. And then from week 9 to week 18, there was about half a day of 30 minutes of physical activity per week. Then when we were comparing the first 9 weeks to the second 9 weeks, we found in terms of vegetable intake, there was about a half a serving increase from baseline to week 9. And then from week 9 to week 18, there wasn't a significant increase or decrease. They pretty much just maintained that increase. In terms of weight, there was a very slight decrease in weight from 192 to 189, so 3 pounds from baseline to week 9. That weight loss was maintained again from week 9 to week 18. Let's see. So just briefly, I thought it's nice to know participants and acknowledge participants who are really making significant strides. So what we did find was there were some clinically significant changes with a good percentage of the population. So of the participants who were, I believe, overweight or obese at the beginning of the program, about 20% lost 5% or greater of their total body weight, which translates into improvements, clinically significant improvements in cardiovascular health. And then when we look at servings of fruits and vegetables, the number of participants who got in their required 7 servings per day, it increased to about 10%. From either 0 to 2% at baseline, it increased to about 10% at the end of the program. And similarly, with 5 days of 30 minutes of physical activity, it went from about 22% at baseline to over 35%. So finally, when we looked at overall the program and after speaking with the PAs, the wonderful PAs, interviewing them as well as the participants, and from my own observations, we came up with a few tips that would be helpful if designing this program over or implementing it again. One of the things that we found was for participants who were acquaintances, because they don't necessarily know a lot about one another and might have a little bit more trouble connecting, possibly matching them based on their particular goals or how often they want to communicate would be helpful. One of the things that participants said they would have liked to do was to meet in person more often, but they just had trouble finding the time. So encouraging the pairs to, once they start working independently and we're no longer coming to class each week, continue to think about that weekly class period as the time that, because they were already blocking it off on their schedule, continuing to think about that as a time where they can get together and actually meet face-to-face or exercise or whatever it might be. Another important thing was helping participants distinguish between a peer supporter and accountability partner. I think because we're in faith communities and accountability partners are very familiar, that's what people had in their mind. But the difference would be accountability partner is more so someone who you do the quick check-ins with, versus a peer supporter might be someone, a peer supporter might be someone that you spend a little bit more time talking through and discussing the challenges and then actually coming up with strategies for how to overcome those challenges. And making that distinction will also give participants the permission to go a little bit more in depth with their partner without feeling like they're overstepping their bounds. We also, along those same lines, we felt like it would be important to do more role play again in how to discuss challenges and how you can strategize through those challenges. And then finally, the final suggestion was to taper classes more slowly. So we went from a class per week to suddenly a class per month. And participants felt like they would have preferred to go from a class per week to maybe a class every other week and then one class per month. And they also felt like after 9 weeks of classes, they did feel like they might be able to go ahead and be the ones to host the every other week class for a month, as opposed to having the PAs come back in. So they felt like they could take ownership of that class, which would be great. So they felt like they could take ownership of a class every other week, and then the fourth week after the formal classes had ended, come back with, the more formal program, the more formal group class, and discuss the challenges and strategies. But they did have that suggestion to taper classes more slowly. And there were a few other suggestions. If we have time, we can go over those, or if someone has additional questions, we can go over some of these other tips. But yeah, I felt like these were the main tips for the peer support part specifically. So that is it from my presentation. I'll be happy to take questions, but I do want to make sure I just send total thanks to North Carolina State University faculty and staff, Annie and Julia, who were just calm as a cucumber and just welcoming in the first place and agreeable to partner with me and help guide me through the whole process of this program and dissertation. The PAs that I worked with and regional coordinators for the original interviews were incredible. They were wonderful. They love what they do. They were passionate, and they made it so easy to complete this program in a way that was made me proud and happy, and I think made our community partners happy as well. The folks at FNEP, who again work with me with all the paperwork, administrative things, Lorelei and Tony, and of course the faith communities and the lay leaders as well. So thank you.
Thank you so much, Cherie. That was fantastic. And so at this point, we can open up for questions. I have one question that was sent to me, but I'm going to answer it for the whole group just so that you all can hear my response. So someone asked if this model, and I'm thinking that means faithful families, could be used by a food distribution or a pantry. That is a, hang on. Hey, Kim, could you take over just 1 second? Sorry about that.
Hi, sorry, I had my camera off. I'm not sure where that question was going, so I'm not sure. I think the question was about a food pantry or a food bank. Was that right? Using the program. So Faithful Families is designed to be a faith-based program that's delivered within faith communities. And I know that there are a lot of faith communities who do operate their own food pantries. And so in that setting, I imagine that that would be great. I'm going to let Annie speak a little bit more to that. And I'm sure that she probably also has some recommendations for other programs that might be more appropriate for a non-faith-based food pantry or food bank setting. I know that she can speak to that much more eloquently than I can. So we can come back to that, but if there are other questions that people have, looks like there's one question in the chat from Viola Barnes Gray. Oh, there's Annie.
Sorry, I'm very sorry.
So I don't know if I gave a great answer to that question, but so you may want to round back on what you were saying before you left.
So could faithful families be used by a non-faith community setting? So ideally, faithful families, the way that the program was designed, is to be used for an organization and a faith community that's all together. Because one of the things that people do during the classes is they make plans to implement changes that will impact that particular faith community. So, so the conversation and the dialogue that happens during the classes is kind of rooted in, okay, well, we're within this particular religious community. What changes can we make to the meals that we serve or to the things that we do? So it's not a great fit for something like a faith-based food pantry because you have people coming from all sorts of different religious communities. There are other programs, and so I'd be happy to, if you want to send me an email, and I can put my email in the chat. There are other programs offered through cooperative extension or through local health departments that would be a better fit, I think, than faithful families. So Viola had a question about the 3 churches that participated, and I'm not sure if you are able to share that, Cherie, with IRB requirements.
Let me see, I'm not muted, am I? No, I'm not. I'm not sure either, but if I have your email, I can find out and get back with you.
So Viola, if you'll just share your email with Cherie, that would be great. And
Privately, yeah.
Yes, and she can get back with you. One question that I had, Cherie, and this is kind of related to your lessons learned, is if there are folks who are interested in doing kind of peer support work as an add-on to Faithful Families or maybe an add-on to another health promotion program, how would you suggest that they could get started with that? Like, what are some concrete things that they could do to build maybe a peer support model?
I would say one of the things that was important was to have that little 90-minute training session where you talk about Dyadic peer support. That's really where you're laying the foundation. You're allowing people to discuss how they're going to talk and communicate with one another. That's where you're allowing them to bond and, figure out what their goals are going to be. That's where you talk about, again, the challenges that they might come across and how they should start thinking through them. As I said, some of the important things that I would probably do over is making sure there's more time to do role playing with the challenges. And in terms of matching, pairing people up, that was something that we had to think a lot about. I think that having participants decide who they want to pair with was great. But I think also having the option of if you're willing to pair with anyone, We tried to frame it that way, not if you don't have anyone to pair with, but if you're willing to pair with anyone, help anyone, be of service to anyone else in your church, then, you know, we'll try and pair you up with someone who has your same goals. That I think would be helpful and would make sure that kind of help with the bonding of participants who are acquaintances and aren't quite as familiar with one another. So having the training session, making sure that you are matching people. And I did find that participants, one of the reasons why participants kept coming back to the program, is that they did like having the clinical measurement. So if you are doing something where when they come back to the church, they can see their progress. If they have some type of number that can show them their progress, that is, I think, helpful as well. And that can be done independently. They can use their numbers from the doctor. You can, if you have funds for, if you were going to do, you know, blood pressure or weight or something like that, you know, you could always get a blood pressure cuff or a scale and they could log it themselves. I think we probably also could have bolstered up the team bonding. So we tried to do, you know, make your own team names and let's post a picture of the teams. But unfortunately, that was kind of an add-on and we didn't have time in our 90-minute session. But I would say that would be something else that you can incorporate, is having teams, you know, think of their team name and have a picture. Another thing that the participants really enjoyed was, again, with the measurements. After the first 9 weeks, we told them, you know, you're going to come back for this 10th week, which was different. This was a new part of the program. But one of the reasons why they were interested in coming back is because we took results that we got from the surveys and we share that information. So we weren't just collecting information just to have data so that we could then go and do, you know, some statistical analysis on it just for us. We shared that data with them and they were excited to see how the church did overall. So we looked at, you know, what was the change in blood pressure, what was the change in weight from baseline to 9 weeks. And they were really excited to see that, you know, there had been some positive changes. We could have done the same with looking at fruit and vegetable intake or physical activity. Sometimes participants don't know how well or how not so well they're doing. So just sharing that information, I think, can help drive them participating and continuing to come back and being excited about working with a partner. The other thing I think would be neat is if you have another faith community that you're working with, you can always do a little friendly competition. You know, that's always fun as well. So I would say those are places to start. And I would say also making sure that when you have participants work on their own, that you don't leave them to work for the entire time independently, that you do have a check-in so that they know that there is support available. They don't feel totally abandoned. So I think that midpoint check-in was important. So I would say those are some places to start.
That is really helpful. And I think it sort of echoes some of what we've seen over the summer and conversations that we've been having about how to maintain contact during COVID-19, right? And how difficult people are finding that. But finding ways to build relationships, to maintain relationships, to help people stay connected are increasingly important. And so in addition to all of these things that Dr. Conley has shared today, we definitely encourage you all to make use of things like the resources from the virtual walking challenge as ways to do that. And that could be some way of like building peer support and encouraging people to team up. You know, and there are resources available on our website for that if you're interested. So
yeah, and I would say that the teams that were able to pair up and actually get together for walking specifically, you know, even if it's socially distanced, they talked about the benefit like the mental benefit, and with it being a faith community, they also talked about the fact that that was a time where they were able to kind of pour back into themselves and connect with God. And even if they didn't get together and walk together, they might have scheduled off a certain time where they were each going to do their walking, and then they would, after they did their walking, did you walk? Or before they were going to do it, did you walk? How did it go? So they knew they had this specific time when they were going to walk, and just the anticipation of knowing that this other person was walking and thinking about what they got out of that little bit of time when they were both walking, both kind of committed. It was more than just the physical aspect. It was definitely the spiritual and the mental and social aspect of being able to be connected.
Mm-hmm. Which I think, I think that's one of the things that I think a lot of people were aware of before, but even more people are becoming aware of the importance of mental health and social support and care for each other, and how much that matters. And we're seeing that, in times of intense crisis like we're in right now, those things really, we need those kind of strong bonds and things to be able to support people. So it's really wonderful to think about how to build that out in our programming moving forward, and how to support it even right now as people are going through the pandemic.
Absolutely.
Does anyone have any other questions for Cherie, for Dr. Conley? All right, well, hearing no questions, I want to make a couple of announcements. But first, I just want to say thank you so much to Cherie for sharing this research and sharing this work. It has been an incredible journey to get to work with you and to get to work with the educators that you worked with on this project. And it just really has been a partnership, and we're so appreciative and have learned so much. And I think there are really wonderful ways, and you've shared some of these, that we can all think about our programming, whether it's Faithful Families or whether it's another program that you do, and how to build in peer support and how to help people make connections with each other, and how those connections are the things that can really build kind of long-term change. And so thank you very much. It was a really wonderful presentation.
Thank you. Absolutely.
And I do want to make a quick announcement, or two quick announcements. This is like a kind of perfect segue. We are working as a Faithful Families team with some faculty members in social work here at NC State, and with some other partners on developing some mental health resources. One of the things that we saw come out of the Faithful Families, the virtual walking challenge over the summer, was exactly what Cherie said, that some of the things that people would just send me emails, or those success stories or things that we read, was about, yes, it's important that I'm walking, but even more important, or just as important, is that I'm finding time to take care of myself, and finding time for thinking about my emotional and my mental health. And so we will be launching in 2021 some similar programming to the virtual challenge, but around mental health themes. So it will be free and open and available for anyone who would like to use that. But we're working on that right now. So more soon. So we'll have a webinar and more information to share with you all about that in the coming months. And then the second thing that I wanted to mention, and I will put a link to this in the chat, is there is a webinar that I am doing with some other colleagues, some folks who might be on this call now, I can't tell, but about PSE changes in Faithful Families for the Society for Nutrition, Education, and Behavior. And I didn't realize until today that it's actually a free webinar. And so I'm going to put a link in the chat here for that webinar. It's on Monday at 1. And if you click on that link, you can see the link to, or the information about how to register for free. There's a code that you put in the registration. So if you're interested in that, that's about Faithful Families implementation at the University of Tennessee, the University of Arkansas, and at the University of Florida. And so we're really excited to share some results from that project. So that is what I have to share with you all, unless I'm missing something. If anybody has any announcements, or Kim, if I missed anything. All right. Well, thank you all for your participation today and for your participation always. We will put this up on our YouTube channel. And again, thank you to Dr. Cherie Conley for sharing your wisdom and your and for leading this really wonderful project. We really appreciate all that you have done. So thank you. And my apologies for having to step out earlier. I don't think I said this, but Sophie, my 6-year-old, was doing virtual PE and fell. And so that was the crying you heard in the background. So we had a little PE emergency, but we're all doing the best we can these days. She's totally fine. Yeah, so Laura Lee says it says there's a charge for the webinar on the website. If you scroll down, there is a code. It says if you are not an SNEB member, here, I'll just put that in the chat as well, but it's on the website, the code. Yeah, so you can put in the code to get free registration. So enjoy. You all have a great rest of your week and take care. It was good to see people. Thank you again, Cherie.